Hello everyone and welcome to our module on endocarditis. Technically, endocarditis means inflammation of the endocardium of the heart, but when we refer to the clinical disorder of endocarditis, what we're talking about is inflammation and usually bacterial infection that involves the cardiac valves. When this happens, it often leads to a new regurgitation murmur. We'll talk more about that in a minute, and sometimes it can even lead to heart failure. And this is usually a consequence of bacteremia. Bacteria get into the bloodstream, they travel through the vascular system, and they usually end up depositing on the cardiac valves, and that is endocarditis. Shown on the screen is an echocardiogram of a patient with mitral valve endocarditis. This is the left ventricle where I'm pointing at the bottom of the screen. This is the left atrium at the top of the image. In between the atrium and the ventricle is the mitral valve, and this is one of the leaflets of the mitral valve, and attached to it is this big collection of bacteria and inflammatory cells. You can see it's flopping around and flicking around inside the cavity, and that is endocarditis of the mitral valve. Patients with endocarditis have general symptoms reflective of systemic infection and inflammation. So remember that bacteria are in their bloodstream and they have systemic inflammation, so they often develop fever and chills and sweats. Another classic finding in patients with endocarditis is petechiae. Petechiae are small red spots in the skin that are caused by small vessel inflammation and leakage of blood. These are some petechiae on this patient's leg right here. These larger spots are called purpura, but petechiae and sometimes purpura can be seen in patients with bacteremia and endocarditis. Another common problem in endocarditis is regurgitant valve disease. If you remember that mass on the mitral valve I showed you 2 slides ago, you can easily imagine how that mass can disrupt the valve and keep it from closing properly. This can lead to regurgitation. So for example, patients with aortic valve endocarditis develop aortic regurgitation, mitral valve endocarditis leads to mitral regurgitation, and tricuspid valve disease leads to tricuspid regurgitation. Pulmonic regurgitation is relatively uncommon. Endocarditis involving the pulmonic valve is very rare, but that can also sometimes occur. Hopefully you also noticed in that echocardiogram image that mass was very mobile, and you can imagine that a little piece of it could easily break off, and if it did so, it would travel with the bloodstream and deposit in distal organs and tissues. So for this reason, embolic symptoms commonly occur in patients with endocarditis. In particular, they can have stroke from pieces of the vegetation traveling to the brain. They can also have spinal cord involvement and paralysis, and you can also see all these other types of embolic signs and symptoms. They are all related to the fact that there's a large collection of inflammatory cells and bacteria on one of the heart valves, and those cells and bacteria can break off and travel to organs and tissues with the bloodstream. The stigmata of endocarditis are a collection of classic physical exam findings seen in endocarditis. These are all caused by septic emboli or immune complex deposition. These are extremely rare in the modern era. They're virtually unheard of. These used to occur 100 years ago before there were antibiotics, when patients would have long-standing chronic endocarditis. However, these do often come up on your exam, so you should be familiar with the stigmata of endocarditis. One of the classic stigmata of endocarditis is the presence of a Roth spot. These are findings that you see in the retina when you examine the eye with the fundoscope. It's a red lesion with a pale center in the back of the eye. Osler's nodes are painful bumps on the pads of the fingers and toes, and Janeway lesions are non-tender red spots or macules that you see on the palms and soles. And then finally, splinter hemorrhages are little red-brown lines that you see under the fingernails. They look like a splinter of wood, and that's where the name comes from. Years ago, something known as the Duke criteria were developed for diagnosis of endocarditis, and this is something you're often asked about on rounds as a medical student. So the major Duke criteria are the presence of positive blood cultures, meaning blood cultures that grow bacteria, or a vegetation that's seen in an echocardiogram like the one we saw a few slides ago. The minor Duke criteria are fever, presence of risk factors for endocarditis, or presence of the stigmata of endocarditis. So to make a diagnosis of endocarditis using the Duke criteria, you need to have either 2 major criteria, 1 major and 3 minor, or 5 minor. And in actual clinical practice, usually we make the diagnosis of endocarditis based on the 2 positive major Duke criteria. A patient has positive blood cultures, and we see a vegetation in an echocardiogram, and we then say that that patient has endocarditis. The signs and symptoms of endocarditis and the diagnosis are fairly straightforward. What they're going to want you to know for the step 1 exam is the microbiology of endocarditis. In other words, which bacteria cause endocarditis. Shown on this slide are all the potential causes of endocarditis. Most of them are bacteria, although there's also something called culture-negative endocarditis that we'll talk about, and something called Liebman-Sachs endocarditis, which does not involve bacteria. And for your step 1 exam, they're going to want you to know the typical presentation of all these causes of endocarditis. Staph aureus is one of the classic bacteria to cause endocarditis. Recall that Staph aureus is a gram-positive cocci. They are catalase positive. All staphylococci are catalase positive, and they are also coagulase positive, and this distinguishes Staph aureus from Staph epidermidis and other coagulase negative staphylococci. And the classic group of patients to become infected with this bacteria and develop endocarditis are IV drug users. They inject this bacteria into their veins using dirty needles, and because the veins travel straight to the right heart, they tend to develop endocarditis of the tricuspid valve. Staph aureus is a very dangerous bacteria when it causes endocarditis. It causes an acute form of endocarditis, and by acute, I mean that patients get sick very quickly. It's a rapid onset severe infection. The symptoms develop over days. These patients often have tachycardia, and they can have low blood pressure and respiratory distress, all from a severe inflammatory response that comes on quickly. And because this bacteria is so virulent, it can infect patients who have normal heart valves. As we'll talk about in a minute, some bacteria with low virulence only infect damaged heart valves. That's not true for Staph aureus. You can have completely normal valves, and this bacteria will still cause endocarditis. In other words, patients do not need to have a predisposing valvular heart condition to develop endocarditis with Staph aureus. Besides Staph aureus, the other classic bacteria involved in endocarditis is Viridans streptococcus. This is often called Viridans group streptococci because it's a group of gram-positive bacteria. There are a number of members of the Viridans group, including Strep mitis, Strep mutans, Strep sanguinis, and many others. They are all catalase negative. Remember that only staphylococci are catalase positive. And these are normal mouth flora, so for that reason, they commonly cause endocarditis after some dental procedure where the bacteria are able to get into the bloodstream. Now, Viridans strep is a low virulence group of bacteria, and for this reason, they usually do not infect normal heart valves, but they do affect damaged heart valves. The reason for this is that these bacteria synthesize something known as dextrans, and dextran can adhere to fibrin, but you need fibrin present on the valve, and fibrin is often found on valves where there's endothelial damage. So damaged valves are the classic type of valve to become infected with this group of bacteria. So the classic predisposing condition is mitral valve prolapse. Many patients have mitral valve prolapse and do not have symptoms, but that leads to some endothelial damage, and then if they get Viridans strep in the bloodstream, they can develop endocarditis. Also, because Viridans is a low virulence bacteria, it causes a subacute form of endocarditis in contrast to Staph aureus. Patients infected with this bacteria tend to have less severe symptoms. They're not quite as sick and they don't feel as poorly, and the symptoms tend to come on slowly over several days or weeks. Strep bovis is another potential cause of endocarditis. This is also a gram-positive cocci. It's part of the Landsfield group D bacteria, and it's a normal gut bacteria. And the one thing you always want to remember about this bacteria for your board exams is that endocarditis caused by Strep bovis is associated with colon cancer. In many patients who develop bacteremia and endocarditis with this bacteria, they are ultimately found to have colon cancer, and the colon malignancy is probably the way this normal gut bacteria gets into the bloodstream. Now, to make this more confusing at the med student level, recently Strep bovis was reclassified into a number of subtypes. All of the subtypes are associated with colon cancer, but the strongest association is with subtype 1, which is called Strep galolyticus. So this is the one you might want to remember for your board exams as having the strongest association with colon cancer, although all subtypes of Strep bovis are associated with colon malignancy. Enterococcus can also sometimes cause endocarditis. This is also a gram-positive cocci, Landsfield group D, just like Strep bovis. It's also a normal gut bacteria. It tends to cause a subacute form of endocarditis like Strep viridans, and what you want to remember about this bacteria for step 1 is that it commonly occurs in older men, especially after manipulation of the GI or GU tracts. Most patients who develop endocarditis with this have recently had some type of procedure where their GI tract or their urinary tract was manipulated. So this might include abdominal surgery, maybe a urinary catheter was placed, or classically, especially in an older man, a transurethral resection of the prostate. This is a surgery done for treatment of prostatic hyperplasia. So a man who has this surgery and develops endocarditis a few days later is a classic example of the type of patient that gets enterococcus endocarditis. Prostatic heart valve endocarditis is a special form of endocarditis that occurs in patients with mechanical or biologic valves. Many patients with valve disease are referred for cardiac surgery, and they have placement of either a mechanical valve, which is a metal valve, this is a picture of one on the screen here, or a biologic valve. A biologic valve has a prosthetic ring, and then it has pig or cow tissue in the middle to mimic the presence of normal valve tissue. Patients who develop endocarditis of a prosthetic valve are rarely cured with antibiotics. This is a very big deal. It usually requires a repeat valve surgery for the patient. Now, the bacteria that cause prosthetic valve endocarditis are the same as the bacteria that cause native valve endocarditis, with one exception. Staphylococcus epidermidis is a bacteria that rarely causes endocarditis except in prosthetic valves. So when you read about a case, maybe in a board exam question of prosthetic valve endocarditis, this is the one special bacteria that you want to keep in mind. Staph epidermidis is catalase positive, just like all staphylococci, but it is coagulase negative in contrast to Staph aureus. And there are actually a number of coagulase negative staphylococci, but the most common one is Staph epidermidis. It's part of the normal skin flora and it has a very low virulence. The one time it tends to cause infection is when there is prosthetic material in the body. It has the ability to latch on to these materials. That's why it causes endocarditis in patients with prosthetic cardiac valves. It also can infect intravascular catheters or prosthetic joints. Now let's talk about what's known as culture-negative endocarditis. This occurs when patients have evidence of endocarditis, for example, a new heart murmur, and fever and growth on a bacterial valve that you can see by echocardiography, but the blood cultures are sterile, meaning bacteria do not grow. This is caused by rare bacteria that are difficult to culture, and the two classic causes of culture-negative endocarditis are Coxiella and Bartonella. Coxiella burnetii is a zoonotic bacteria. This means it is transferred to humans from animals. It's an obligate intracellular bacteria that's usually found in farm animals, especially cattle, sheep, and goats. And in particular, veterinarians worry about this bacteria a lot because when it infects farm animals, it causes abortions because it infects the placenta, and this can make it very difficult for farmers to breed their cattle and sheep and goats. What happens to humans, the way they get infected, is that they inhale aerosolized bacteria if they're exposed to infected animals. And when they get infected with Coxiella, the infection is called Q fever. Acute Q fever is a flu-like illness that may present as pneumonia in some cases with coughing and even infiltrates on chest x-ray. However, in more than half of cases, there are no symptoms that the patient recalls of acute Q fever. So a patient who has acute Q fever and doesn't get it treated, maybe because they had no symptoms, then goes on to develop chronic Q fever. And there are a number of manifestations of chronic Coxiella burnetii infection, but the most common one is endocarditis. And that's why this bacteria is often discussed as a cause of endocarditis, because many patients who are exposed to farm animals present with endocarditis. They don't recall having Q fever because they had no symptoms, and they have a Coxiella burnetii infection. There are two species of Bartonella that can cause culture-negative endocarditis. The first one is called Bartonella quintana. This is a small gram-negative rod. It's transmitted to humans by lice. So this is a picture of a louse on the screen here. It's an insect. And in patients with poor hygiene, like people who live in third world countries or homeless patients, they can develop infestation with lice, especially on their clothing, and the lice can transmit Bartonella to their bloodstream, and that can lead to culture-negative endocarditis. Bartonella henselae is found in cats. It's the cause of cat scratch fever. I talk about this in the infectious disease section, and some patients who have cat scratch fever can go on to develop culture-negative endocarditis. Last cause of endocarditis we'll discuss in this video is NBTE, which stands for non-bacterial thrombotic endocarditis. This is also sometimes called Liebman-Sachs endocarditis. It's also sometimes called Morantic endocarditis. It's very confusing. You just have to remember all these different names. In this condition, there are lesions on the cardiac valves that look like endocarditis, but they are not caused by bacteria. That's why it's called non-bacterial endocarditis. One of the hallmarks of this disorder is that the lesions tend to be on both sides of the valve. So if you recall the echocardiogram I showed you earlier in this video, we had the left ventricular cavity at the bottom, we had the left atrium at the top, this is the left atrium here, and the mitral valve leaflets were in the middle. The bacterial vegetation was only on the atrial side. That's typical in bacterial endocarditis. In NBTE, vegetations tend to grow on both sides of the valve. This is unusual and it's a unique feature of NBTE. The most common valve where this condition occurs is the mitral valve, and it's caused by thrombus and immune complexes on the valve, not by bacterial growth. And as you can imagine, since it's caused by thrombus, it's seen in many hypercoagulable states. One of the classic ones is advanced malignancy, especially solid tumors. It also occurs in patients with lupus. NBTE is often asymptomatic and only identified at autopsy after a patient with advanced malignancy dies. The lesions of NBT are relatively small, so they rarely cause valvular regurgitation or heart murmurs. However, the thrombus found in these lesions easily dislodges, and that often causes embolization. This is the typical clinical phenomena that results from NBTE. Bacterial vegetations are sticky from the bacteria and inflammatory cells. NBTE lesions are filled with thrombus. It's not as sticky, and it easily breaks off and embolizes. Most patients who have this condition are asymptomatic until an embolism occurs. An emboli have been described in many different locations, including the spleen and kidneys, the skin and extremities. NBT may cause a stroke. It's even been reported to cause myocardial infarction from embolization to a coronary artery. I'll briefly discuss the treatment of bacterial endocarditis. Several weeks of appropriate antibiotics are usually used to resolve the infection. Broad-spectrum antibiotics are used initially until the bacteria is identified from blood culture. At that point, the drugs are usually changed depending on what antibiotics the bacteria is sensitive to. Valve surgery is sometimes required in bacterial endocarditis. This is often done when the vegetation is very large or when the vegetation leads to severe valvular regurgitation and signs and symptoms of heart failure. You should be aware that in some cases, bacterial endocarditis can be complicated by formation of an abscess beneath the annulus or the ring of a valve. When this happens, antibiotics will not clear the infection because the bacteria are basically hiding inside the abscess. The way this presents clinically is that patients will have persistent fever and bacteremia despite the fact that you have them on antibiotics. And in particular, you should be aware of a high-yield anatomical correlation of this complication. The aortic valve lies very close to the AV node, so an abscess under the aortic valve can lead to AV node dysfunction, and this can lead to heart block. So new onset heart block in a patient with aortic valve endocarditis is highly suspicious for an abscess in the aortic valve. Shown on the screen is an ECG of a patient with a prolonged PR interval. That is evidence of first-degree AV block. And if a patient has a normal PR interval at presentation and then after a few days of treatment for endocarditis develops a new first-degree AV block, that's highly concerning for an aortic valve abscess. And I'll finish this video by mentioning prophylaxis. We sometimes administer antibiotics for primary prevention. In other words, we give them to patients who do not yet have bacterial endocarditis, but we think they're at high risk. It's done before high-risk medical procedures that commonly lead to endocarditis, and it's only given to patients who are at very high risk for developing endocarditis. And years ago, anyone with any type of heart condition was often given an antibiotic before dental work or other procedures. There are now new guidelines that basically restrict prophylactic antibiotics to only the highest risk patients. So the patients that need antibiotic prophylaxis need to have one of the conditions shown on the left side of the screen, and they need to be undergoing one of the procedures shown on the right side of the screen. So the patients at highest risk for endocarditis are patients with prosthetic valves, patients who've had endocarditis before, or rare patients who have cyanotic congenital heart disease. This is very uncommon, or some patients with heart transplant. Now, even if they have one of these conditions, we don't necessarily always give antibiotics unless they're going for a high-risk procedure. The highest risk procedures that can lead to endocarditis are dental work, respiratory procedures, and skin surgery. Antibiotic prophylaxis is usually with the antibiotic amoxicillin. However, if patients have a penicillin allergy, we use clindamycin. And that concludes our video on endocarditis.